Hi, everybody. Welcome to another episode of the Data Doesn't Equal Outcomes podcast. I'm your host, Tristan Keelan from CCNY. The behavioral health and human services organizations have to demonstrate outcomes. They have to run programs that make people better and prove it. And so the mad scramble for data is well underway. But data is just numbers and outcomes are just results. Connecting the two is the work. So if it has to do with driving better results for clients using a data-driven approach, we cover it here on Data Doesn't Equal Outcomes. My guest today is Alyssa Palmer, the Director of Quality at Southside CHS. Southside is a federally qualified health center serving primarily uninsured, underinsured, low-income individuals and families within the Minneapolis, metropolitan area. They lead with a continuous improvement philosophy through education, positive relationships, and psychological safety. Under Alyssa's direction, Southside has achieved formal recognition as the only community health center in Minnesota to be in the top 10% in clinical quality among national community health centers for 3 consecutive years. Standardizing realistic, efficient workflows that are designed and tested by the people closest to the work has allowed Southside to develop their We Always framework, which we'll talk about on today's episode, which ensures that delivering the highest quality care and service to the community is at the forefront of daily operations. Alyssa, thanks so much for being on today.
Yeah, thank you for having me, Tristan.
Okay, so we did kind of a quick overview of Southside CHS and got a few buzzwords in there, but tell us a little bit about your role there and what it means to be a federally qualified health center.
Sure. So my role as Director of Quality is really a combination of compliance, risk. I usually tell people it's anything that has to do with the quadruple aim. So increased or improved patient outcomes, improved patient and staff satisfaction, and then lower cost of care. So a federally qualified health center is essentially a community health center that's federally funded through HRSA. And we really serve all individuals who are primarily underinsured or uninsured and low income with primary medical, behavioral health, dental, and vision services, regardless of their ability to pay.
Right. And being a FQHC, federally qualified health center, does that sort of tie you to specific outcome metrics?
It does. So we are essentially required to show continuous improvement, but we have about 18 clinical quality measures that we report on each year. And at Southside, we keep all of them at the forefront. There's many clinics, I think, that try to focus on certain ones each year, but we try to keep them at the forefront of everything that we do.
Sure. And 18 clinical quality measures at the forefront is no small task.
So. It is not.
No. So we're going to talk today about how, in fact, you manage that. So you employ what you call the We Always approach to QI culture. Can you walk us through sort of what that means and what it means to Southside?
Sure. So when I first joined Southside, and I think this is not unique to our clinic or the history of our clinic, but when I first joined Southside, data and quality was kind of on the back burner. We heard a lot of, we used to do that, but I don't know why we don't anymore. Or we used to do that for a certain grant, but that stopped. So now we don't do that anymore. And so we developed a We Always approach, meaning we always, screen people for depression, not because we have a grant attached to it, not because we're reporting to HRSA, not because we have money attached to it, but we always screen our patients for depression because we don't want them reflected in the staggering suicide statistics in Minnesota. And then we take that approach with all of our clinical quality measures.
Yeah, I really like that. In particular, what you mentioned about grant-funded programs, and it's really easy to find time for quality reporting metrics when your funder requires them, right? It's a little bit different when nobody's knocking to keep them at the forefront. So how did you roll that out? How does we always go from being, an idea to being a company culture?
So a few years ago, back in 2018, when we rolled this out, we actually implemented IHI's Joy in Work at the same time, and which is really just a platform for introducing psychological safety and reconnecting to purpose. And through that, we began telling our own stories, whether they were our own or that of our families, and really just started talking very openly and vulnerably about our own experiences in healthcare and how we did not want those experiences to be passed on to our patients. And it really is what we use to drive this We Always approach, just really staying connected to the work that we're doing.
Yeah, I like that, especially around psychological safety. I think it's a common refrain when talking about clinical settings. It's less common when you talk about administrative functions and in quality improvement and data in particular. That idea that data can be traumatizing to people. It can be very judgmentally viewed, and it's an excellent way to break down that barrier. We always create the data because it shows us how well we're doing, and there's a lot of great stuff that you can tie on top of that. We always start to a statement.
Yeah. In my role as the director of quality, I tell our staff and my colleagues really that it's my job to worry about the data. Their job is to take care of our patients, which is that's their purpose, right? That's why they went into the healthcare to begin with. They didn't go into healthcare to report to HRSA.
Right.
They went in to make sure that our communities are living happy, productive, healthy lives. And so as long as they are keeping that at the forefront of their mind, they do what they do. And as long as we're doing right by our patients, our data falls into line.
Yeah, that's a really important perspective. Almost it's data as a service, not data as a request, right? I'll bring you the numbers that we can talk about. You don't have to bring them to me on top of the work you already do, right? Serving versus requesting. That's great. So you introduced QI in your new hire orientation, correct?
We do. So this was part of our initiative to just change our culture, really, and introduce the psychological safety. And again, like I said, quality was really on the back burner of our organization when I first joined Southside. So this was a way for us to introduce, our initiatives right from the get-go to people entering our organization. Mm-hmm. So we were doing, it was kind of twofold. We were doing the work with the people that were already here. And trying to shift that culture. And then with the people that were new on board, the expectation was already set for them, as soon as they walk in the door.
Right. One of the things that, obviously that does is helps you connect to what W. Edwards Deming called the process owners, the people who can actually change a function, which in QI, that's neither you nor me, right? You need people who are embedded in the processes to decide that they're going to do them differently. So tell us what it's been like in terms of your ability to tap into those creative centers of those who perform the work in your projects.
Sure. So I facilitate patient advisory groups. Or we call them clinical advisory teams, actually, within our organization. But it's really just giving the message that the people who do the work have the best ideas. Again, I can look at the data, but they do the work every day. They've got their hands in the cookie jar, so to speak. So really, they're the only ones that can give us the information that we need. When we do PDSAs and try different systems changes, we know within a couple patients whether or not it's going to work or not. And so it helps really having these people, these smaller groups, really be the change makers of the organization and being willing to try these little tests of change and whatnot so that we can implement them on a larger scale. Very
nice. Sounds like you've got a lot of amazing buy-in. Hard-earned, though. Hard-earned.
It is hard
for
earned,
sure.
Especially, again, coming from a culture that wasn't there. And we did lack some psychological safety for various different reasons. And so when we began to introduce this, admittedly, when we first started advisory teams, it was a little pulling teeth. Not very many people, they weren't quite sure what this meant, how much work was involved. They weren't quite sold that we would actually do what they were suggesting, and as we pulled in more people to these, we had multiple smaller groups. And as we pulled more people in, then they slowly and surely began to trust that we trusted them to know how to improve our processes. And then once we, our data tells our story. So when we saw that what we were doing was working, that just charged them even further.
Yep. Once you get a little bit of success, you can sort of self-promote that within and create that momentum. Yeah. So you mentioned before that there's 18 clinical quality measures for an FQHC, and you're looking at all of them all the time, but you can't be running projects arbitrarily. Talk a little bit about your process for identifying, an intervention, or when a metric needs a project or you need to try something new. How do you don't just throw darts at your 18 measures and pick one. What's your process look like for identifying, the next project for your clinical advisory teams?
So it's really, it kind of all happens simultaneously, honestly. I'm looking at the data every month. And if I see something trending in a unfavorable direction for our patients, then it's time to look at what our processes are. And sometimes what's been working, just for whatever reason, especially during COVID, it just doesn't work anymore. So we have to tweak it a bit. And so, just based on what our numbers are showing, then we'll take a deep dive into a few random charts based on the CQM and find out what exactly is going on. And then we'll pull in the people who are doing the work to say, if not this, then what?
Right.
And then we brainstorm and collaborate, and then we try small things, small tests of change, and then go from there.
Yeah, wonderful.
Now we have actually two clinical advisory teams. We have a preventative care and then a chronic conditions care group. So it's a lot more streamlined than it was back in 2018. There's been some growing, obviously, but this process has worked fantastic for us.
Wonderful. So you have mentioned to me in the past a particular project, and I appreciate your willingness to discuss a little bit of detail, because I think it helps a lot of agencies who are trying to grow their culture of QI and trying to really embrace, PDSA and change plans. And on paper and in theory, it all makes perfect sense, but the practical application is, sometimes out of reach for a lot of agencies. So I think when we can tell these stories, it really, really helps everybody. So the project that you had told me about was around colorectal cancer screenings, and maybe you can, help us understand a little bit what the expectation is, and then, we can kind of talk through how that project went.
Sure. So, to begin, I would say too that I think that with QI projects, we tend to make them much larger in our mind than they need to be. Actually, the more simple, the better, and the more successful. And so with our colorectal cancer screening, when I first joined Southside back in 2017, our colorectal cancer screening rate was at 47%. And I had actually come from private OBGYN where our numbers were actually much higher. So to know that I was working with a primary care clinic with a lower rate was, concerning. I knew that we could do better. And so we looked at our process, and we happen to use a form of Epic for our EMR. And I discovered that when we gave patients their at-home IFOB kits for colorectal cancer screening, when they returned them, they needed to schedule a lab appointment so that our medical assistant who was running the lab in-house had something to attach it to, an appointment to attach it to. And then it occurred to us, as we talked about the current process, why aren't we having patients just schedule their lab appointment when they're given the kit? That way they get an automated appointment reminder through our system that we use for appointment reminders. And then if they no-show, they get a reminder. So it takes the onus off our low resources that we have, for contacting patients. And then, and really just puts it in the hands of our patients to get their appointment scheduled before they leave the office. And we tried it with 10 patients right off the bat. And all 10 patients, when it was followed, to a T, all 10 of them returned their kits within 2 weeks. And so we implemented it and we made it our process. And the 2 months that we had right after we implemented that, we shot up to 70% for our colorectal cancer screening.
That's an astounding improvement.
It is. It's and it also speaks to our total cost of care. Before we were just handing out these kits and they were disappearing because people would forget about them,
Yeah.
So it was like throwing dollar bills in the air, and so it was successful on all fronts.
Mm-hmm. And they typically are, right? Usually whatever you hone in on for improvement, it usually has ancillary improvements.
Right. Yeah.
They either have to happen to achieve it, or once you achieve it, they spin off into something else that you weren't even trying to do.
Absolutely. Right? Yeah. And it speaks to our, our advisory teams are interdisciplinary. So we have representation from our front desk staff too, who used to do or who does, I should say now, the scheduling of the lab. So, everybody's got a piece in it. And then everybody also has a voice in it as well. So that helps.
Right. So now I want to go back through the project, and, it's funny that you said usually simple is, the best way to go. So I'm going to go back through your project, if you don't mind, and try to simply explain how you do it. So I think this is where a lot of people get lost. Yes, you had the metrics. Yes, you had a change plan. Yes, your test group performed well and you got your improvement. This is going to sound silly, but logistically, what did this look like? Did you meet in a room? Did you meet via Zoom? Like, how do you activate your clinical advisory teams? Like, what does it look like to be in your seat and actually, initiate a project like this that resulted in an amazing improvement?
Sure. So we had our clinical advisory team. We looked at our our colorectal cancer screening rates. I shared with them my experience in my previous role and thought that we could do better. And then from there, again, because it's a multidisciplinary team, each person who had a role in the process explained what happens. And so when we kind of laid that out on paper, we could. It was very easy to see. I mean, it was almost like this light, was switched on, going, why don't we just do it this way? Oh my gosh, it's so simple. It alleviates so much. And we tried it. We had a nurse that looked through the schedule and, picked some random patients that were due for their colorectal cancer screening. We tried it on them and it worked.
Yeah. I love that you said you put it on paper, right? So even if you have, 3, 4, 5 people involved in a process, if they document their part and they're all separate, it doesn't expose anything, right? When you take 4 people's part of a process and put it together and everybody can look at it, it paints a picture and you go, yeah, okay, we can clearly identify what it is we can do.
Yeah.
Write it down is a huge lesson.
Yeah.
Here,
well,
right?
And I think we get into that mindset of, we always do this, or, or we've always done this. And and that's actually, I think, one of the most damaging mindsets that we could have in quality improvement. But,
yep.
Getting it on paper and just realizing just how simple it is, or not simple. Sometimes we've written things down that we're doing and we go, why on earth are we doing that this way? we've got this fantastic EMR system that could be helping us.
Right.
Better,
Right. So you get it written on paper. You've got your test team in place. The results on your test are perfect or near perfect, right? So how do you go from a 10-person test group to this is our forever policy, or this is our new permanent process? How do you make sure that it gets expanded?
Yeah, so what we do is, in my role, I write our policy out with our procedure as well. And then at our medical staff meeting, we introduce it. We go through it, in its entirety, and we teach it, explain it, and then we kind of handhold for the first couple of days. I do some behind the scenes, just checking. We did at one point, we called it a competition, where we had, we had a list of patients that were due for their colorectal cancer screening, and it was kind of a competition between care teams to make sure that each part of the process was completed with these patients. And again, and the ones that completed it, from A to Z, it worked perfectly. Patients brought their kits back correctly. They were done correctly. Mm-hmm. And two, that helped us see also that for the patients that the process wasn't followed, they still weren't returning their kits. So it just helped our staff also notice that, hey, this actually does work.
Yep. And going back to your we always, if early detection is a huge driver in being able to treat any type of cancer, then, here you are, substantial amounts, getting people screened early and often. That's going to make a difference.
Absolutely.
Right?
And absolutely. And, we have one of our providers that we work with, she's kind of championed our colorectal cancer screening, but she has a close family member who had passed away from colorectal cancer screening. So again, it ties back to our purpose and, not wanting our patients reflected in those numbers.
Yep. Yeah, that's great. Okay. This is a wonderful story. And I had something that I was going to ask, and it's escaping me. Oh, yes. So when you see a successful an improvement like this, and we talked about momentum and culture, what do you do with these results? How do you show maybe other teams that, hey, look what we were able to do. And when it's your turn, you'll see that this culture, this process produces successful results. It's not arbitrary. It's not about checking a box. Do you do any kind of either internal or external promotion about, when you successfully implement a change process?
We do. So, internally, as I mentioned earlier, we are measuring we're looking at our CQMs every month. And we share that data at all of our staff meetings each month. With just a real simple scorecard with green, red, and yellow, that shows people if we've improved from the month prior and how close we are to our goal. Each year we have a 5% improvement goal, capping at 95%. And so people are aware of where we're at. And then we're also part of a collaborative in the Twin Cities that we are required to share our metrics each month with a group of 10 other FQHCs. And so with that too, we're looking at each other's data and going, hey, how did you get your numbers up to this? And we're sharing that all the time. And also, with being an FQHC, thankfully, as a community health center, it's actually a very tight knit group. So we're always reaching out to one another to look for ways, for improvement, whether or not we adopt a process entirely or if we tweak it and make it our own. We're always looking for ways to improve and ways to share, our improvement.
Yeah, I appreciate that comment because there's a lot we can learn from each other. And if you're one particular clinic finds something that works, I love the idea that that gets shared instead of becoming secret, because we're all in sort of a public benefit here. It's not about patenting your colorectal cancer screening process, right? It's about getting more people pre-screened for cancer so that we can make an improvement.
There's definitely a competitive culture in healthcare, I think, and when we don't share, we're just we're losing sight again of the purpose, right, of healthier communities and healthier individuals. So we are happy to share anything.
Yeah, that's wonderful. So I also want to say thank you, because what you have done today, I think, is, fairly vulnerable and doesn't happen that often, not just personally, but as an agency. And this is something that I'm, feel very strongly about, that admitting that your quality improvement team improved quality should be a positive thing and not seen as an admission that you weren't somehow providing quality before, right? Like, we should celebrate these stories. And if our focus is on continuous and always moving the needle, then, we got to get out from under the fear of our metrics and, not be afraid to tell people that we were only so good before and now we're better. And, I love that you're proud to tell this story. So
yeah, we definitely drive on a know better, do better.
Improvement improvement is the goal, as opposed to any particular, right? How do I explain this? There's measures that show whether you improved within a project, but the project itself being successful should be celebrated. That there's a 1 for project successful, right? So I think it's important for folks like you to get out and tell these stories. And so I really appreciate it.
Thank you.
One last parting question. If you were to have a first-time quality improvement director in front of you coming on board, and they said, Alyssa, I'm about to take a seat exactly like yours, what's the best thing that I need to know to be successful? What advice would you give that?
Oh my gosh. I would say, well, I have a lot, but I would say, be open and talk to your colleagues. Again, the people who do the work have the best ideas. And if they trust that you genuinely believe that, they will share what works and what doesn't work, for that matter, and be teachable. It's we often come in with our own ideas, and some of us are pretty steadfast on making sure that what we have in our mind plays out, but it doesn't always work that way. So we need to be nimble and teachable.
Excellent. Thank you. We'll go ahead and that wraps up today's conversation. This has been Alyssa Palmer on the Data Doesn't Equal Outcomes podcast. Alyssa, thank you so much for being with us.
Yeah, thank you, Tristan.